Okay, let's start with pupillary control. We have a couple things here, meiosis and mydriasis. Let's talk about the first thing, meiosis. Meiosis is the constriction. It is the constriction. It is done through parasympathetic, through M3 receptors on which the acetylcholine is going to work. Okay, as compared with, let's just compare it first with the mydriasis, which is known as, which is the dilation of the sphincter pupil. And it is done through sympathetic nervous system, which is alpha 1 sympathetic nervous system, alpha 1 receptor. Okay, so let's just take a look at meiosis, first neuron and a second neuron. Let's dive into this picture now to figure out the first and second neuron. So for meiosis, the first neuron is from Edinger-Westphal nucleus to the ciliary ganglion via the cranial nerve 3. So let's just take a look at that. From first, we are looking from here, from the Edinger-Westphal nucleus. Let me zoom in so you can take a look. From here, from this point all the way, it's going to, in the ciliary ganglion, which is here, right? And from ciliary ganglion, it's going straight to the sphincter pupillary muscle, here, to the muscle. So second order neuron, so we said this is the first order neuron. The second order is from short ciliary nerve to the sphincter pupillary muscle. So this is the second order neuron. So let's take a look one more time. So this is the first order from this Edinger-Westphal nucleus all the way to this ciliary ganglion. That's all first order. And from here all the way towards this sphincter pupillary muscle, the second order neuron. That's exactly what they're saying. So we have a first order neuron, second order neuron. Simple as that. But what do we need to know is, high yield point is that for meiosis, the muscle that is going to constrict is the sphincter pupillary muscle. So here's the mnemonic: short ciliary nerves shorten the pupil diameter. So let me see if I have an image here. So let's just take a look at this image to make sense. You know, this is sphincter pupillary muscle right here, which is sort of circular muscle, which has an M3 receptor on it. And the contraction of the sphincter muscle will lead to decrease in the size of pupil right here, which is known as meiosis. It is done through parasympathetic because it is the M3 receptor, which is normal, like for example, pilocarpine. But it's also done if you give sympatholytics, which are alpha 2 agonists, or opioids. High yield opioids would also cause meiosis, except meperidine. And this is again, this picture is from general. Okay, just got it from there. So, and the last one is organophosphates. Okay, what we really need to know is just meiosis is decreasing the pupil size is meiosis. It is done through sphincter muscle contraction, because the other one, which is mydriasis, it will be done through radial muscle contraction. Look, both are contracting. That's the thing here. Both are contracting, but one is causing the pupillary size to decrease, and the other is causing the pupillary size to increase because it's the radial muscle on the periphery. So it's going to stretch it up, stretch it open. Normally, you need direct sympathomimetics. That's going to cause it, but other drugs are anticholinergics and indirect sympathomimetics like amphetamines, LSD, meperidine, all of that. Let's get back to our basics that we were talking about, and that is this part. meiosis and mydriasis. So we got these two neurons. We got the sphincter pupillary muscle. Now let's take a look at the mydriasis first, and then we will come back to this pupillary light reflex. So mydriasis, let me just erase this part. Mydriasis, it is the dilation through sympathetic. It has first neuron, second neuron, third neuron. So let's take a look. It is quite long. So let's just take a look at from one side, from one first to all the way third. So start from hypothalamus. Let's just put H here. H is there, so that's the first. Okay, and it goes to where? To the center of budge, which is C8 to all the way to T2. So let's say from here, it's going all the way to approximately, let's say T2 from C8, remember? And second order neuron, let's change color. Second order neuron, and why is this important? Because you will see in Horner syndrome, in any point given case here, where you can destroy the nerve fibers and it will give you some damage. So second order goes from T1. So let's just say T1 is the main point, the center of budge, right? From here all the way to the superior cervical ganglion. So from here all the way it goes back up top, which is the superior. So let me just do it the other way. Superior cervical ganglion. It travels along the cervical sympathetic chain near the lung apex and subclavian vessels. Now let's take a look at the third neuron. The third neuron is going from this plexus along the internal carotid through this cavernous sinus, enters the orbit at a long ciliary nerve to pupillary dilator muscle. So all the way from here towards the eye, and to the eye it goes to the pupillary dilator muscle. Sympathetic fibers also innervate smooth muscles of the eyelid, minor retractors, and sweat glands of the forehead. Okay, this is important. Let me read it one more time. So all they're saying is that you have, where did it go here? Third order neuron. Sympathetic fibers also innervate smooth muscles of the eyelid, which are the minor retractors of the eyelid, sweat glands of the forehead and face. And this will come next, what we'll see in Horner syndrome, how it's going to show up. Okay. Now the mnemonic here is the long ciliary nerves, because here these were the long ciliary nerves. They make the pupil diameter longer, right? Longer diameter, meaning wider diameter of the pupil. Shorter diameter of the pupil, meaning decrease the size of pupil. Okay, so this is, keep this in head, and that's pretty much for mydriasis, right? So let's just take a look at now the light pupillary reflex. Pupillary light reflex is light in either retina, send signal via cranial nerve 2. So let's say the light is here. Let's just give an example. We shine the light here. It's going to go from retina. This is retina all the way back there, right on both sides. It's going to go from which nerve? Cranial nerve 2. So this is all cranial nerve 2 to the pretectal nuclei. Okay, look at the pretectal nuclei is right here. Now, if you look here, it's going to the pretectal nuclei and pretectal nuclei, both sides. Now, that one pretectal nuclei will activate bilateral Edinger Westphal nuclei. That's important. So let's just take a look at this. What are we saying here? So we are saying that this optic, let's say we have a light. Let me erase this part. We shine light here. Let's just give an example. This goes from this retina all the way from this, from the optic nerve, CN2, all the way goes back and stimulates what? The pretectal nucleus, right? Now this one pretectal nucleus, if you take a closer look here, it's going to stimulate both sides of Edinger Westphal nuclei, both sides. Look, this fiber is going here and here. So what's going to happen now is that from this side is going to constrict the pupil, and the other side is also going to constrict the pupil, right? So let's just read this. Bilateral Edinger Westphal nuclei, pupil constrict bilaterally. That's normal. It's called direct and consensual reflex, meaning when you shine the light in one eye, that's direct constriction of the pupil. That's direct reflex, right? But the other eye automatically constricts the pupil. That's called consensual reflex now. Okay. Okay, what is the result of this light reflex? Illumination of one eye results in bilateral pupillary constriction, right? Simple, right? And this is normal, like pupil light reflex, normal reflex. You shine the light in one eye, both of the eyes will constrict. Why? Because pretectal nuclei, this guy innervates both sides of the Edinger Westphal nucleus, and those will cause constriction. Simple. Now we will talk about defects. Now the defect of this is called the relative afferent pupillary defect, which is also known as Marcus gun pupil. Here what we have is extent. Let's just read this first. Extent of pupillary constriction differs when the light is shone in one eye at a time due to unilateral or asymmetric lesion of the afferent limb of the pupillary reflex. Example, retina, optic nerve. I'll talk about this, but here let's just read the whole thing first. When the light shines into a normal eye, constriction of the ipsilateral eye, direct reflex. So let me just have the eyes here. When we shine the light here, okay, this is the normal eye, let's say. There's the constriction of the pupil here. Simple, right? It is known as the direct reflex. And the contralateral eye, which is the consensual reflex. So this also constricts due to consensual reflex. When light is swung from normal eye to an affected eye. Now this eye was affected. Let me change color to red. This eye was the affected eye. So now when we shine the same light now onto the affected eye, what's going to happen? Now, because we have a problem in the afferent, meaning what is afferent? When you're going towards the brain, when you're taking everything towards the brain, to the nucleus, that's the afferent. Coming in is the afferent, right? So this, something is wrong with the afferent, which they have mentioned. For example, a problem could be in retina, problem could be in optic nerve, could be there. So either we have a retina problem or either we have the optic nerve problem. Something is there. But when we shine the light in the affected eye, this is the affected eye, when we shine the light here, let alone that this would constrict, it will not constrict because it's not getting the signals, because there is a problem in the conduction. And it's not going to let the other guy constrict because the whole connection is out. There is no connection. Exactly what they write here is called when the light is swung from a normal eye to an affected eye, both people dilate instead of constriction. It's the opposite what they're doing. They were supposed to constrict, but when you have a problem, they dilate. That means there is a problem in the afferent limb of the pupillary reflex, and that is why it's called the relative afferent pupillary reflex. Meaning afferent, something is wrong here in the afferent fibers. Okay, and that is due to either the retina problem or the optic nerve problem. And most commonly, why do we have, what can you think of when we think about the optic nerve? Do you think of optic neuritis in multiple sclerosis? Yes. So most common thing, optic neuritis in MS. Okay. And that's about it. So let's just quickly go through this page and move on to the next one. So I think this is now making sense. So it's pretty easy. So I'll just quickly go through it. So, okay. Here what we have. Simple, simple. So meiosis is all about constriction done through parasympathetic M3 receptor. Okay. First outer neuron, second neuron. First neuron is all about from here all the way to ciliary ganglion. This is first. So from Edinger-Westphal nucleus to ciliary ganglion, and from ciliary ganglion all the way to the sphincter pupillary muscle. That's the second neuron. Important point is short ciliary nerve, which are here terminal nerves that do the job, which is the shortening the pupil. They are the nerves, right? So short ciliary nerves shorten the pupil diameter. For the mid-recess is all about dilation, and all you got to think about is something is coming from hypothalamus all the way to about T1, which is known as the center of budge. From here it goes back upward towards the superior cervical ganglion, and from there it goes towards the eye. And in eye they would innervate the radial muscles. Where are they? Pupillary dilator muscles, which are also known as the radial muscles. Okay, and they would dilate the pupil. Okay, and the mnemonic here is long ciliary nerve make the pupil diameter longer. Okay, then we have here the afferent defect. As the name suggests, you have an afferent defect, afferent pupillary defect, meaning either you got the problem in the retina, either you got the problem in the optic nerve. Most common optic nerve problem is the optic neuritis, which is seen in multiple sclerosis, MS, right? Okay, and here what's going to happen is when you shine the light, let me just do it here. When you shine the light in normal eye, both eyes will constrict because everything is going normal. But when you shine the light in abnormal eye, the connection is lost because there is a problem there. So nothing is going to go from here to all the way there. So when nothing goes there, this guy is going to dilate, and this guy doesn't even know it's going to dilate. So that's the problem. That's called the afferent pupillary defect. Something is wrong in the afferent fibers, which are examples, retina and optic nerve. Okay, let's move on to the next page, which is the Horner syndrome. Okay, in Horner syndrome, it's the sympathetic denervation of the face, which will cause ptosis, meiosis, and hydrosis. Try it. Ptosis, meiosis, and hydrosis. Let's take a look at on the left side. So from hypothalamus, we are getting this first neuron that goes all the way from hypothalamus and synapses in the lateral horn. From the lateral horn, the second neuron arises and it travels in the towards the superior cervical ganglion, right? And from superior cervical ganglion, now the third neuron gives and innervates couple of structures. So for us, it's if you look at these nerve fibers, they're going and innervating the forehead sweat gland, the facial sweat gland. So guess what? If you knock out these nerves, you're not going to have the sweat glands in the forehead and the face. So you are going to cause anhidrosis of the face and of the forehead. But this is not notable much. Ptosis and meiosis are highly notable in a patient, right? So let's take a look at the other one. Then the other fibers, they are going and they are innervating. Look at this muscle. They're innervating the eyelid smooth muscle. When you knock this out, you will not be able to innervate the eyelid smooth muscle. So you can't contract. So you're going to get the drooping of the eyelid, which is the superior tarsal muscle, which is known as ptosis, drooping of the eyelid, ptosis, right? And lastly, look, it's going and it's innervating to the pupillary dilator muscle. What were they doing? They were dilating the pupil, right? They were increasing the pupil size. That is exactly what we talk about in mydriasis. Pupillary dilator muscle increase pupil size. But now when you knock this out, So you are going to get meiosis, which is pupil constriction. Simple. Let's do it one more time quickly. We all know it's ptosis, meiosis, and hydrosis. No, I mean, you know it, I know it, everybody knows it. But here's the thing. Here's the thing. How? Because these nerve fibers, when they come out of the superior cervical ganglion and they supply these structures, each structure they supply is going to get knocked out. When each structure is getting knocked out, it's going to cause its effects, which is anhidrosis for these two. For pupillary dilated muscle, you can't do it anymore. It's going to cause meiosis. Eyelid smooth muscle, you can't contract it anymore. It's going to cause ptosis, which is the drooping of the eyelid. Okay, so meiosis, ptosis, meiosis, and hydrosis. Now, how do we knock them out? What is the cause of the problem? So it is associated with lesion along the sympathetic chain. So this is a sympathetic chain. Along the sympathetic chain, something went wrong. So in the first neuron, due to pontine hemorrhage, lateral medullary syndrome, spinal cord lesions above T1, Brown-Sequard syndrome, late stage syringomyelia, all of them can knock down your first neuron, which is right here. And it's going to cause all these symptoms again. You could knock out any one of them and cause same thing, right? So let's look at the second one now. Second neuron. Second is stellate ganglion compression, high yield. By the Pancoast tumor, high yield. Pancoast tumor compresses the stellate. I mean, sometimes they mention Pancoast tumor causing compression to cervical ganglion. That's not the case with the Pancoast tumor. Pancoast tumor is going to compress the stellate ganglion. I think it's also in respiratory, I believe. You can also take a look over there. But here, third neuron from the carotid dissection, painful carotid dissection, because it's running against, look, it's circling around where? Internal carotid artery, right? So if you have a carotid dissection, you are going to again knock out your sympathetic innervations, leading to all of this Horner syndrome. It's going to cause everything but anhidrosis is absent. And why is anhidrosis absent? If you take a look, these fibers are already going before they can actually look at this. So if we have aneurysm here or dissection here, you're knocking out your muscles and not the facial sweat gland. So anhidrosis is absent. Okay, so that's pretty much it for Horner syndrome. Let me see if I have anything extra for this. Horner syndrome. So yeah, that's pretty much it. Nothing much. Let's look at the next thing, which is called ocular motility. Okay, simple. No rocket science about it. All we gotta know is this mnemonic, which is LR6 SO4R3. Lateral rectus by CN6. SO4 superior oblique by CN4. And R3 means the rest of the muscle by third cranial nerve, CN3. So that's what they mention here, the same thing as I just said. Okay, taking a look at this image, let's take a look, where are they present? Okay, so lateral rectus is on the lateral side, medial rectus on the medial side, superior rectus, superior side, inferior rectus, inferior side. The two new muscles, not new, but two other muscles which are not to their names, which is one is inferior oblique and superior oblique. One important thing for superior oblique, there is a pulley mechanism on the superior oblique through the trochlea. So it goes through the trochlea and then gets on attached to the eyeball. So taking a look at this here, it's going to make things easy. Okay, look at superior oblique. It starts here, goes through this trochlea, and then goes back. Okay, and inferior oblique is going the other way. Okay, now So let's just read this. Errors in illustration depends direction of the gaze, which to test each muscle. Obliques go opposite. Okay, that's a very good one. Obliques go opposite. So uh, left superior oblique and inferior oblique tested with patient looking right. Okay. IOU, inferior oblique tested looking up. So these are tests that you can do in order to figure out which muscle is out. But more important here is this blowout fracture. Simple but important. Is the orbital floor fracture, usually due to trauma to an eyeball or infraorbital rim. Taking a look at this picture. So this is eyeball. So normally you should have this this bone being fully. There shouldn't be any opening here, right? So since there is an opening here, it's orbital floor fracture. So you can see this is the floor of the orbit. There's a fracture. That's why there is orbital structures are coming out of it, right? So here. And why? Question is, why would it happen? High yield trauma. Trauma to the eyeball. Punch. Eyeball. Punching on the eyeball. There was a fight. Somebody punched someone. Here you go. They, they are going to present with diplopia and something, and you take a look on imaging, you find, okay, wow, there is a blowout fracture because of the orbital floor fracture. Because why? Because this is the very, it is prone to fracture, this lower part, prone to fracture, okay? Increased risk of IR muscles and or orbital fat entrapment. So inferior rectus can entrap in this, as inferior rectus is at the very bottom here. So it can entrap, and or orbital fat can also be entrapped here. May lead to infraorbital nerve injury also, okay? And this is a very high yield image. Okay, now the next thing is called strabismus. Strabismus is all about misalignment. It is a deviation of the eye towards the nose, astropia, which is known as astropia. So here's the eye, here's the nose. Now, when you deviate the eye towards the nose, it's called esotropia. Is the most common type of strabismus in children. Complications include amblyopia. I hope I'm saying it right. Amblyopia, yeah. Diplopia and adverse psychosocial impact. First, let's talk about amblyopia. Amblyopia is the lazy eye, meaning decreased visual acuity due to maldevelopment of the visual cortex. So you have a maldeveloped visual cortex that's going to cause decrease in visual acuity, caused by abnormal visual experience earlier in life due to strabismus. So strabismus complication is amblyopia, which is lazy eye. Typically unilateral, only one side is affected. Okay, so let's just recall this strabismus again. It is the misalignment in children. If you see something in a child, one eye is misaligned, it is deviated towards the nose, okay, and that's strabismus. But it could complicate into amblyopia, which is that side would not even develop because it was a child, right? So it wouldn't develop. That's just going to decrease visual acuity, okay. Diplopia, double visioning, and because they're going to look pretty, they won't look good, so they will have a psychosocial impact as well, because they will have some psychosocial impact because how they look, right? So this is strabismus and amblyopia. Okay, quickly going through this page again. We got the Horner syndrome, pretty simple thing. Horner, ptosis, meiosis, anhidrosis. Let me zoom in. Okay. Knocking out these structures are going to give you all of that. And it is due to stellate. Important thing is stellate ganglion compression by Pancoast tumor and carotid dissection. Okay. Ocular motility, LR6, SO4, R3, blowout fracture, is all about fracture to the eyeball or trauma to the eyeball, uh, causing this inferior rim to fracture because it is prone to fracture, causing IR, inferior rectus entrapment, because IR is at the very bottom, right? Okay, so that's what we have with this load fracture. Then we have strabismus. Is going to be misalignment of the eye, which is the crossed eye, for example. Deviation of the eye towards the nose. Esotropia is most common type, and it can cause amblyopia, which is maldevelopment of the visual cortex, causing decrease in visual acuity. Okay, diplopia, double vision, and adverse psychosocial impact. Okay, that's pretty much all. Moving on to the next is the cranial nerve. Cranial nerve 3, 4, and 6 palsies. Okay, here all we have is, let's talk about the first one, which is the CN3 palsy. It's the oculomotor nerve. Oculomotor nerve. Now, important thing about oculomotor nerve, which is high yield, is that it has a central part and a peripheral part. Central part, it is the motor part, and the peripheral part is the parasympathetic outflow path. Okay, so let's just read it, and I will explain anything that comes up here. So CN3 has both motor, which is central again, and parasympathetic, which is periphery components. Common causes include, so CN3 damage common causes include ischemia. Ischemia leads to pupil sparing because the motor fibers are affected more than the parasympathetic fibers. And that's high yield. And it will come up, and we will talk about that in just right now. But here, the second part is uncal herniations lead to coma. PCOM, posterior communicating artery. Aneurysm, that's again high yield, and we'll talk about that in a moment. Is a sudden onset headache. Okay. Cavernous sinus thrombosis, it leads to proptosis, involvement of CN cranial nerves 4 and 5, V1, V2, and 6. And that's, we will see that in cavernous sinus. Midbrain stroke leads to contralateral hemiplegia. Now is the important part, that the central part, it is the motor part. It sends the outflow to the, because it's a motor. So guess what motor thing are we looking at in the eye? All the extraocular muscles, like muscles of the eye, are the motor things. So the central part supplies the ocular muscles, extraocular muscles. So if you affect the central part, if you knock this out, what's going to happen, which, I mean, you knock it out where and when? You knock it out in any ischemia, vascular disease. For example, in diabetes, where you have the glucose that just goes and forms sorbitols, leading to ischemia, leading to damage to the nerve, the central part of the nerve, and also due to decreased diffusion of oxygen and nutrition to the interior, which is the middle part, from compromised vasculature that resides on the outside of nerve. Now, important thing is, if you knock this out, what is that? So you got the whole idea, but now the important point is, if you knock the middle part, which is the motor, so middle motor, right? If you knock it out, you're gonna have ptosis and down and out gaze of the eye. Let's take a look at here. So you have ptosis, because remember, the motor part was supplying to the extraocular muscles. So when you knock out the muscles, you are going to get this ptosis. Not only ptosis, but also down and out gaze of the eye. Okay. But high yield point that you have to remember is the ptosis. Why is the ptosis? I'm going to talk about the other one now, which is the periphery. Periphery, which is the parasympathetic. So periphery P for parasympathetic outflow. If you recall just back right now, we talked about meiosis was done through, meiosis is the construction of pupil, is done through parasympathetic nervous system, right? So if you knock out this periphery, which is the parasympathetic fibers, what you can do is now you will not be able to constrict the pupil. So you are classically going to see a blown pupil. So let's read this now. Parasympathetic output leads to fibers on the periphery are first affected by compression. Okay, you could, if there is a compression like PCOM, posterior communicating artery aneurysm, is going to compress which structure first if there is a PCOM here? Well, it's going to compress the periphery, right? And that is going to cause the damage to the parasympathetic outflow, and it will lead to diminished or absent pupillary light reflex. That's one thing. All right. Second thing is blown pupil, which is just dilation of the pupil, because now you can't constrict it. Now recall who was constricting this pupil. Well, the constriction was done through parasympathetic fibers, meiosis, right? Parasympathetic fibers. You're knocking out these parasympathetic fibers. You cannot do meiosis anymore. So you're just going to go into mydriasis, unopposed mydriasis, which is blown pupil, right? Often with down and out gaze. So if you look at down and out gaze, is both, you see it in both of these things, but only thing ptosis, you don't see it in the parasympathetic outflow. Let me just highlight this part, ptosis, and here you have this blown pupil. So ptosis and blown pupil are the different features. Taking a look at this picture on the right side, what do we have here? So middle equals middle central parasympathetic periphery. So M for middle, P for periphery, simple. That's all cranial nerve, right? Now taking a look at ptosis, down and out gaze, which is the motor part. If motor part is affected, then you get down and out gaze. Okay, and if you have a parasympathetic, if you get a parasympathetic, the periphery of this optic nerve, my bad, oculomotor nerve, CN3, right? If you get the palsy of the periphery, which is the parasympathetic, you are going to get these features, which are, you will not be able, you will have a diminished absent light reflex, because if you recall, light reflex needed the CN3, right? Okay. And on top of that, you are with very high yield. That is this thing right here, blown pupil. Here is the blown pupil, and here is the important thing is ptosis. Okay. With the motor part, you are going to get ptosis. So you can say, okay, if you see a ptosis, you will think about, okay, it's the CN3 motor part out. I mean, you will get something similar in both of them. If you look here, down and out gaze, in both you're seeing that. But I'm just talking about something specific for motor, ptosis. For parasympathetic, which is the periphery. And remember, the motor is the middle part. So let's just draw that actually. So here's the nerve, here's the middle part. This is motor, this is periphery. And periphery, blown pupil and absent pupillary light reflex. Okay. And this is all about CN3 damage. Look, and I'll go through it one more time, but here let's just look at this CN4 damage. CN4 damage is going to cause, if this is the trochlear nerve, if you damage the trochlear nerve, high yield thing is you will see a tilting of the head. Head will tilt. Look here. Impaired in intorsion, which is intorsion is like looking medially and inward. So let's this is the eyes. These are the eyes. Medially and inwards. For example, you're reading. You need medial, right? Medial and inward reading. You are going on stairs. You need this medial inward. That's called intorsion, right? So you will not be able to either read or go on stairs. So let's look at that now. Here is the CN4 damage, which is the trochlear nerve. And it's going to cause, pupil is higher in the affected eye. You can see the pupil is higher in the affected eye. Characteristically, you will see head tilt to the contralateral unaffected side to compensate for the lack of intorsion in the affected eye. So head is tilting to compensate for impaired intorsion. Okay. Can't see, now mnemonic is can't see, high yield mnemonic, very easy mnemonic. Can't see the floor with cranial nerve 4 damage. 4 floor. So you can't see floor with the cranial nerve 4 damage. Example, difficulty going downstairs and reading. And why? I just mentioned that you need this trochlear nerve. Remember, this trochlear nerve was supplying, so LR6, SO4, SO4, superior oblique. Superior oblique, the function of superior oblique was to, for the reading, medial, inwards and medially. The function was to move the eye inward and medially. Right? And that is the function of trochlear nerve. Let me just double check something here. Superior oblique, yeah, turns the eye down and in, yeah. So here, down and in. So here's the eye, down and in. That's the that's the superior oblique. For example, reading in, going downstairs. So when you damage the superior oblique, now you can't have this intorsion. So the head will compensate and tilt towards the affected side. And that's what this CN4 damage. Now looking at the last one here is a CN6 damage. CN6, which is the abducent nerve damage. Okay. Affected eye would be unable to abduct and is displaced medially in the primary position of the gaze. So here all you have is, if you recall what it was doing, the CN6, the normal function of CN6 was, again, LR6, lateral rectus. What is the function of lateral rectus? Is moving the eye laterally, right? So now here, when you knock out you have a damage on the abducent nerve, you will not be able to move the eye to the lateral side. Here, what it is, it's called impaired abduction. You can move it laterally. So this is the normal eye, and the abnormally impaired, the eye with a problem, it won't be able to move on towards the lateral side. Okay. And it will be in position of the primary position of the gaze, meaning it will just look straight, nothing else, no movement on the lateral side. Now, importantly, the CN6 damage is seen in something known as pseudotumor cerebri, which is just increase in ICP, right? Increase in ICP that leads to CN6 damage or CN6 palsy. Pseudotumor cerebri, one of the important cause of this. Okay, and that's going to be all. Let's just quickly go through these nerve damages and palsies and move on to the next one. Erase all of this. Okay, easy. Okay, let's just quickly go through them. Very easy. All you got to know is simple things and keep things simple, okay? CN3 damage. CN3 is the oculomotor nerve. When you damage the middle part, which is the motor, and that most commonly occurs with a vascular disease, diabetes, or any oxygen problem, vascular disease again, compromised vasculature, it's going to knock out your middle part, which is the motor supply. When you knock out your motor supply, you knock out your extraocular muscles, causing ptosis and down and out gaze. With the periphery, if something compresses on the periphery, that's the most common cause, and you knock out the periphery, right? So parasympathetic is going to be out. With the parasympathetic being out, who's going to push on it is the PCOM aneurysm or uncal herniation is going to push on this and cause compression and cause damage to the parasympathetic, the periphery of the CN3, which is the parasympathetic. It's going to cause periphery with the parasympathetic, we normally we needed that parasympathetic for what? For constriction, for the eye constriction. Now, when you knock this out, you cannot constrict anymore, so you're going to have a dilation. So it's the blown pupil with down and out gaze. So here the blown pupil, here's the ptosis. Two different things and two different structures. Not structure is one, but only two different sides of one cranial nerve. Okay. Now the other one is now CN4 damage, which is the trochlear nerve. Superior oblique damaged. Normally superior oblique, the function of superior oblique is to look down, inward and down in intorsion. When you knock this out, you can't do intorsion, meaning you can't read and you can't go down on stairs. And for the compensation of that, the head is going to tilt. So it's the trochlear nerve palsy. Okay. With the CN6 damage, which is the abducent nerve, with this damage, again, remember this LR6, normal function, moving the eyeball laterally, right? So when you can move it laterally, so one eye will be immediately, and the other eye is just going to look straight because you can't move laterally. So right here, as seen in the picture, you have impaired abduction. Abduction is impaired, or moving laterally is impaired because lateral rectus, the damage is there. And why is the damage, or what are the most common causes of this damage? Is going to be the pseudotumor cerebri, which increase in ICP leads to CN6 palsy. Okay, and that's all for the cranial palsies. Moving on with the visual field defects. Here, all we have is, let's take a look at picture first. Simple. Okay, the first thing we have is left eye, right eye. Here's the problem in the middle, right? In the middle, if you recall, we have macula, right? We have what? Macula. And if you recall, the macular degeneration was age-related macular degeneration. Macula, okay, let me just write it down. Macula is the center of vision. If you knock out macula, your central vision is going to be knocked out. So here, with just one point in the center being knocked out, you can say, okay, macular problem is called central scotoma, which is the macular degeneration. Simple. Right? Now we have left side and anopia. Anopia is the whole left eye is just out. You can't see nothing from that left side. Right? And that, if you look here, for example, that's going to happen in the optic nerve problem. If you knock the optic nerve out of that side, it's going to give you left side anopia. Right? And what are the causes of this optic nerve? Again, the optic nerve, whenever you think about optic nerve, just think about optic neuritis. Always optic neuritis. Where is it seen? It is seen in MS. It is seen in MS. Okay, it is seen in MS, and you have another cause, and that is going to be, if you recall, something called TIA, transient ischemic attack, right? That has a transient loss in the one eye, monocular vision loss. You can just read, but this is how you'll point. The TIA, you have something called amaurosis fugax. Amaurosis, let me write. Amaurosis fugax. I mean, I don't know the spelling here, but fugax. Okay. And this is just a transient monocular, meaning one side only, vision loss. It is seen with the transient ischemic attack. Okay. And that's also can cause anopia. Now, moving on with the third point here, is called the optic chiasm. Here is the optic chiasm now. If you knock this out in optic chiasm, you are going to get bitemporal, meaning the temporal sides, both the temporal sides are going to be knocked out. Half side, temporal meaning half sides, right? Heminopia, only the temporal sides are knocked out. Okay. And that knocking out of temporal side is seen with tumor, for example, pituitary tumor aneurysm. So let me just write it down. pituitary, tumor, and aneurysms, right? Now, from here, what happens is that you have this part. Let me write this down here. I haven't mentioned. So this is the lateral geniculate nucleus. Lateral geniculate nucleus. From here, two fibers, they arise, and one is called the Meyer's loop, and one is called the dorsal optic radiation. So that's exactly what we're going to talk about. So when we hit the Meyer loop, when we knock this Meyer loop out, this is the Meyer loop. You can read it there. And the other one is what? Dorsal root radiation. When you knock this Meyer loop out, it's going to cause deficit in the upper quadrant. So upper quadranopia. Upper quadrant is going to be knocked out. It's called upper side quadrant, right upper quadranopia because of the right side, but quadranopia, upper quadranopia. Important thing that sort of a keyword here is going to be pie in the sky. It's a pie in the sky. Okay, pie in the sky. Because you see it's looking upward, right? So pie is in the sky. With the dorsal root optic radiation, it's the lower quadranopia. So when you're talking about lower quadranopia, you're going to call it pie on the floor. Quadranopia, right? Only the quadrant is out. So pie on the floor because you're looking down, the vision loss is down at the lower quadrant. So pie on the floor. So pie in the sky and pie on the floor. The last is, let me erase this part. The last is here, which is the visual cortex. Here we have this right homonymous hymenopia with macular sparing. Here's the macula. Macula is spared. Why? Because macula is spared. It is supplied by an MCA. So if you have a PC infarct, which supplies the visual cortex, PCA supplies the visual cortex, right? So when you have a PCA infarct, you're not going to cause full-on hymenopia, but you will have a macular sparing. Macular sparing again, why? Because macula is supplied by MCA. Okay, so in PCA stroke, you will have macular sparing homonymous hymenopia, and that's all about this. So let's just read now quickly and move on to the next. So here's the visual field defects. Ventral optic radiation, which is the Meyer loops, is the lower retina, travels along the temporal lobe, loops around the inferior horn of the lateral ventricle. Dorsal optic radiation, the other one, it's superior retina, travels around the parietal lobe. So that's how they are different. Let's just recall this and move on to cavernous sinus quickly here. Let me do this. Better understanding. Simple. Macular degeneration. Macula is the central part. You degenerate the central part of the visual field. You're going to call it macular degeneration, central scotoma, right? And if you knock out your whole one-side vision, that's the optic nerve problem. Could be done in optic neuritis or in the emesis fugax with the TIA. Optic chiasm could be knocked out in leading to first of all, it's going to cause bitemporal heminopsia. Temporal sides are out. It is seen with pituitary tumor aneurysm, right? Optic tract. Now this is the optic tract. You knock this out, you're going to get right homonymous hymenopia. Okay. Right homonymous hymenopia. With the Meyer's loop, this is the Meyer's loop. That's the pie in the sky. With the dorsal root radiation being knocked out, that's the pie on the floor. Visual cortex being knocked out, that's the homonymous hymenopia with macular being spared because MCA supplies the macula. Okay. And that's pretty much what we have for visual field defects. Moving on with the next thing here is the cavernous sinus. What is cavernous sinus? Well, it's the collection of venous sinuses on either side of the pituitary. Blood from the eye, the superficial cortex, leads to the cavernous sinus, goes into the internal jugular vein. Again, blood from eye and the superficial cortex, all the way, all this blood goes into cavernous sinus, which all drains into the internal jugular vein. Okay, this cavernous sinus, CN3, 4, 5V1, V2, and 6, plus the postganglionic sympathetic pupillary fibers en route to the orbit, all would pass through this cavernous sinus. And there's a picture down so we can take a look at that. But so these all structures will go through this cavernous sinus. Cavernous portion of the internal carotid artery is also here. What artery? Internal carotid artery is also runs here. So the mnemonic they have is I, tomato, which is internal carotid artery, trigeminal nerve, ophthalmic and maxillary divisions, abducent nerve, trochlear nerve, and oculomotor nerve. That's the eye tomato. So let's take a look at the structure first. So the structures are, here are the structures. So we have internal carotid artery. You see this part, internal carotid. And we have 3, 4, 6. So just, you don't have to, if you can do the mnemonic, great. If you don't, if you can memorize the mnemonic, just remember CN3, 4, 5, 1, 2, and 6. So 4, 5, 6, right? 4, 5, 6. It's all about the fifth one. CN5 is just one in first and second part, not the third part. But maybe if you just remember this 3, 4, 5, 6, they run within this within this cavernous sinus with this internal carotid artery as well. They run in the cavernous sinus. And why is that important? Well, it is important because when you compress the cavernous sinus, you are going to knock out all these structures, and that's going to give a lot of problem. For example, how can you compress it? Well, you can compress it by any tumor, by any thrombus or fistula. Tumor, thrombus, fistula, anything that compresses the structures, that's going to compress this cavernous sinus, leading to compression of all of these. So they will present with variable ophthalmoplegia. Why? Because you're compressing CN3, 6, decrease in corneal sensation, Horner syndrome, and occasionally decrease in maxillary sensations. Secondary, why would you have it? Because of pituitary tumor, mass effect, carotid cavernous fistula. Okay, so a tumor, mass, fistula can compress the cavernous sinus, leading to cavernous sinus syndrome. Or even within thrombosis within the cavernous sinus can also lead to that, right? Related to infections, right? Spread due to lack of valves in the dural venous sinuses. Now, important point is what sort of infections are we looking at within the brain, right? So the infections, most commonly, the common pathogens for this infection is Staph aureus. We don't think about it, right? Staph aureus, wow. So infections, most common is going to be Staph aureus being most common that causes it. And you can also think about other, let me just write Staph aureus first. Staph aureus, other than that, you can think about streptococci. Fungal organisms are also important. Let's just write some fungal organism. For example, mucor and rhizophus. Mucor, rhizophus. But these are rare. Most important is going to be the Staph aureus. Staph aureus being the most important cause of infection within this cavernous sinus. And infection can spread from, so you ask, okay, how are we going to get this infection up top over there in the brain, right? So that's the infection can spread as a from the medial third of the face or the sinus. From the if you look here, we have the sphenoid sinuses, and we also have, which is not in the picture, we have the ethmoid sinuses. The infection can go from there, or even teeth. So infection can go from here all the way into the cavernous sinus. Staph aureus being the most common organism. Streptococci and some fungal infection organisms are also rare cases, but they're also there. Okay, so let's just recall one more time this thing and move on to the next. All you got to know is cavernous sinus is all about 3, 4, 5, 6, and internal carotid. You have these structures run within this cavernous sinus. Anything that compresses this cavernous sinus, or anything that there's an infection, the tumor that compresses it, or fistula or thrombosis due to infection, and that can cause problem in these structures, and you will have variable ophthalmoplegia because CN3, CN6 involved, corneal sensation decrease, Horner syndrome, decrease in maxillary sensations. Let me erase this, and you can see decrease in maxillary sensations are also there. And yeah, that's pretty much it for the cavernous sinus and cavernous sinus syndrome. Moving on with the, again, very important topic, that is the intranuclear ophthalmoplegia. Now, intranuclear ophthalmoplegia, here, it's a very simple one if you understand it. But if you don't understand it, then it's going to be huge pain, right? So let's just try to understand it first so we don't go through the pain, right? So all we have in this one is going to be, let's just take a look at picture first, because pictures make sense. Why can't I zoom in? There you go. Okay. So we have this frontal eye field. So frontal eye field is like, okay, I want to look to the left. There's a pizza there. There's a Coke. There's some cheesecake. Something is there, but I got to look on the left side. Okay. So the brain is like, let's look at the left side. Okay. So it's going to send the signal all the way to something called PPRF, which is paramedian pontine reticular formation, PPRF. This structure right here. Through PPRF, there are signals that go to abducent nucleus, abducent CN6 nucleus. So from here all the way to CN6. So CN6 would do what? Again, what are we trying to do? We're trying to look at left side. We want to look towards the left side. Okay, so CN6, it has a direct supply to the lateral rectus. It goes, it's like, okay, man, just turn left. We good. Lateral rectus moved the eye to left side. The left eye moves to the left. But what about the other eye? If you move this eye towards the left, that's going to be opposite. It's like, well, I don't know what you're going to look like, but it's going to be something pretty bad, right? So one eye is looking here, the other eye is looking that way. So what we need to do is we want one eye to use the lateral rectus, but the other eye to use the medial rectus to move in one place, right? So exactly what we need here. So we have this again. We have CN6 nucleus. It supplies to the lateral rectus and it moves towards the left. Now CN6 also, through these fibers, which is called MLF, medial longitudinal fasciculus, sends the fibers to CN3 right here. Let's change color. CN3 to cause the medial rectus to also move, to also, contract the medial rectus so that you can move the other eye medially, so you have both eyes looking at the one direction, right? So again, what did we talk about till now? Okay, simple. Again, doing one more time. We have this thing called paramedian pontine reticular formation. We start here. From paramedian pontine reticular formation, it sends signal to the cranial 6. Cranial 6, now again, what was the question now? The question is we want to look at the left side. Okay, so cranial 6 sends these fibers to the lateral rectus. So lateral rectus means looking towards the left side. That's good. But on the other hand, from the other eye, we need the medial rectus to be stimulated. So there is something very high yield that is known as MLF, medial longitudinal fasciculus. And that MLF is going to cause the medial rectus contraction, and so that the medial rectus also goes towards the left side. Medial rectus moves it towards the right side, but if you look at the eyes, both are looking towards the left side. That's what I meant. Okay. Okay, now with this, let's read the book. So, simple things first. Internuclear ophthalmoplegia is basically lesion of MLF. Okay, so let's read first. So medial longitudinal fasciculus, which is MLF, which is a pair of tracts that interconnect two nerves, 6 and 3 nuclei. They coordinate both eyes to move in the same horizontal direction. They're highly myelinated. Why? Because they want to have a quick communication between each other. Must communicate quickly, so I move at the same time. If you move towards the left right now, look, there is no difference because of that myelination, high myelination, right? Lesions may be either unilateral or bilateral. The bilateral lesions are seen in multiple sclerosis and stroke. So now let's talk about what are the lesions, or if you have a lesion, what's going to happen. So lesion in MLF. So here, let's just look at here. So if we knock this out, this guy, this is the MLF, right? If we knock this place out, now just without looking up top, just see here. So you get the signals here in the PPRF. That's going to go to the cranial nerve 6. From 6, it's going to go towards its side, which is the lateral rectus. But when it goes towards the other cranial nerve 3 side, nucleus of the cranial nerve 3 to supply to the medial rectus, there is no connection. So the one eye, which is not getting connection, is just going to look straight. And because cranial nerve 6 will try to send that signal again and again, right? So that it would contract towards the left side. Now the CN6 one is doing again and again. This is sending signal on the both sides. So it's going to cause nystagmus here. So this eye will go back and forth, nystagmus. So let's read now. So lesion in MLF, which is the internuclear ophthalmoplegia, INO, it is a conjugate horizontal gaze palsy. You have a lack of communication as such that when the cranial nerve 6 nucleus activates the ipsilateral lateral rectus, the contralateral CN3 nucleus does not stimulate the medial rectus to contract. So abduction, which is lateral side, abducting eye, meaning let's just here. This is the abducting eye, right? So looking at from the lateral rectus, abducting means going laterally. So abducting eye displays nystagmus. So this eye will display nystagmus. And because CN6 overfires to stimulate CN3, which I mentioned, right? And convergence is normal. What is convergence? Both eye looking medially, right? That's why is that normal? Because that's not done through this pathway. That's a total different pathway. So we're talking about we are not talking about convergence, but we are talking about lateral gaze, lateral gaze, right? Okay, so let's look at one more time again in the picture and move on to the next thing. So simple thing, what are we trying to figure out in the MLF lesion? So in the MLF, let me just use a red pen. Here is the MLF. Here's this one. When you have a lesion here in the MLF here, so signal is coming from the PPRF to the cranial nerve 6. So all good, right? Cranial nerve 6 is sending the signal to the lateral rectus. All good. The eye is moving towards the laterally. So abduction on one of the eyes, right? On the ipsilateral eye, right? But the other eye, the contralateral eye, which was going to get signaled through MLF to, it stimulates MLF, through MLF is going to stimulate this cranial nerve 3 nuclei, but this is not going to happen because you have a lesion here, simple lesion here. You cannot stimulate CN3. So when you cannot stimulate CN3, you will not be able to stimulate medial rectus. So this side is just like, hey, I don't know nothing, so I'm just going to look straight. I have no clue what's going on, right? So it's going to look straight. But the other eye, this eye, which is following all the command, it's going abduction, right? But the CN6 is like, hey, I'm trying to send signal, but nothing is working. So what it does, it overfires. It's like, keep sending the signal. When it keeps sending the signal is not going one way only, it's going both ways. So when the signal is going both ways, this is not going to go through, but this is going through. When it is going through, so it's going to cause nystagmus because it's overfiring. So this eye is like, what's going on? I'm like, it's just going to fire and fire and fire, overfiring, causing nystagmus. So here, that's what they have mentioned. Abduction, eye displays nystagmus. CN6 overfiring to stimulate CN3, and convergence is normal. That's another story because that's total different pathway. Okay. So looking at here, you have the right INO. A right gaze is all good. Left gaze, you're trying to do left gaze. The one which did the abduction is going in nystagmus, going back and forth, while the other guy is just impaired abduction, looking just straight up. Convergence is normal. You can't go left side, so you're just going to go straight up, okay? Straight, it's just going to look straight, and that is all. So looking here, MLF is an MS, multiple sclerosis. When looking towards the left nucleus of the CN6 fires when which contracts the lateral rectus and stimulates the contralateral right nucleus of the CN3, while the right MLF to contract the right medial rectus. So directional term, right INO, left INO, refers to the eye that is unable to adduct. INO is the ipsilateral adduction failure. So that is a mnemonic here. INO is the intranuclear ophthalmoplegia, right? So the mnemonic here is INO, meaning ipsilateral adduction failure, nystagmus, opposite, meaning you can't adduct, meaning you can't look towards the middle part. Adduction is not there, so there's a failure of that, and the other eye is just going to nystagmus. Nystagmus in the opposite eye, INO. Okay. Okay, now looking at this one, okay, a right INO, left INO refers to the eye that is unable to adduct. Let's just take a look, dive deep into this one, which is pretty easy. So let's take a look at what's really happening, right? So here we have, let's just do a normal thing here. So we have a right eye, left eye, okay? That's normal, right? So when we try, so let's say you have a left eye, meaning the left eye will not be able to move medially. So when you have let's say you have a right gaze and a left gaze. Okay. So when you have, let me just do the normal here. So right gaze, meaning going towards the right, here's the right side, right? And left is going towards the left, and this side is the left, right? Now with the left eye, what's going to happen is when you move towards the left eye will not be able to move. This is the left eye. The left eye will not be able to move on the right side. Okay, so again, what is left eye? Meaning the left eye is affected. The left eye is affected, so left eye will not be able to move towards the right side, which is going to be, for example, so wait, let's just focus here, and then I'll talk about the mnemonic here. So there is another thing called right INO. The right INO, again, opposite of this, which is going to be, you will not be able to have the right gaze. You can't do the right gaze. in the right eye, no. Okay, so if you're the summary is that if the eyes cannot move to the medial side, so you have two eyes, right? If one of the eye cannot move towards the medial side, the other eye is already moving towards the lateral side. That's normal. The eye which is moving towards the lateral side is a normal eye. The eye which is not moving towards the medial side is the one affected, right? So that will be INO, that there is an MLF problem on that side. Okay. So again, in simple terms, the affected eye, let me write this down here. The affected eye can't move medially, which is the adduction. So the affected eye can't move medially. Here, classic scenario here, this guy is looking left, great, but this eye can't move medially. So you have this, this is the problem. This is the MLF, meaning this is the problematic eye. This has the MLF lesion, or INO, which is intranuclear ophthalmoplegia. I hope it makes sense. Let's just recall this quickly and move on to the next. It's a very simple one if you understand it, okay? All you have to know is simple. Again, very simple. That you have this PPRF, which is the paramedian pontine reticular formation, which sends the signals towards the CN6. CN6 has to send to two areas. Again, the question is that we are trying to move both eyes towards the lateral side. So one eye will be moving laterally and the other eye will be moving medially to look at the same side, right? So with the PPRF sending signal to CN6, it's going to fire that it's going to go into to the medial longitudinal fasciculus, and it's going to directly go into this lateral rectus, and that is going to cause, on one eye is going to cause abduction, and the other eye through CN3 is going to cause medial rectus to move medially, and so that both eyes can look towards the same direction, right? If you knock this MLF down, now what's going to happen is, let me just change color. You knock it down. Now what's going to happen is the CN6 will work on its ipsilateral side, right? And one eye will be moving in abduction. And because there's a signal problem here, so CN6 will keep firing. That firing is going to go bilaterally on both sides because there's a problem in conduction there, or there's a lesion, so there is no conduction. So this eye will be looking just straight, while the other eye is just going to go into nystagmus because of the rapid overfiring of the CN6. That's the MLF, and that is all we have. Again, INO is all you got to know is INO equals lesion in the MLF, which is right here, lesion in the MLF. And that is all. Let's move on to the next thing. It's called the eyelid disorders. Preseptal cellulitis. Preseptal and orbital cellulitis, okay? Preseptal is the anterior soft tissue eyelid infection. Anterior. Mild presentation with unilateral ocular pain, swelling, and erythema present at rest. With the orbital now, instead of being anterior part of the eye, now you are at the posterior eyelid infection, causing, when you go in posterior, now it's going to entrap the whole orbit. So posterior eyelid infection affecting orbit contents. Now the muscles of the orbits are going to go into that inflammation. Pain with ocular movements. So you had ocular pain, swelling, and erythema at rest. Here you have pain with ocular movements, infection affecting the orbital contents, like for example, fats and muscles. Usually it is secondary to bacterial sinusitis. So you have a bacterial sinusitis. That sinusitis goes and causes or goes into the orbit, causing cellulitis, orbital cellulitis, orbit, the whole orbit gets involved. So you get pain, double vision, diplopia, and ocular movement pain. Okay, so double vision with ocular movements. So risk of vision loss is there, cavernous sinus, and that can go contagiously go into the cavernous sinus again, and that can lead to cavernous sinus thrombosis. Intracranial from cavernous sinus can travel into intercranial part, most commonly caused by Staph aureus and streptococci. Staph aureus and streptococci are most common cause. So the difference here is preseptal, again as the name says, preseptal, anterior part of the eyelid infection, orbital, the whole orbit at the posterior part gets involved. And the orbit can seed into cavernous sinus and can seed into the intracranial spread. And most common organism was aureus and streptococci. Then you have the blepharitis. Blepharitis is eyelid margins and lid inflammation, irritation, and encrusting. What two structures? Eyelid margins and lid inflammation. It's called blepharitis. Then you got hordeolum, which is sty. Sty is an acute infection of sebaceous or sweat gland of the eyelid. So eyelid has sebaceous and sweat glands. If they get somehow they get inflamed, maybe there's a blockade causing inflammation. That causes tender erythematous nodule right on the eyelid. Right on the eyelid, right? Right on the eyelid, you will get tender subcutaneous nodule. Then you have the chalazion. Chalazion is a non-infectious granulomatous inflammation caused by obstruction of the meibomian glands, which are modified sebaceous gland, or Z's, which are sebaceous glands. So chalazion is, first of all, it is non-infectious. What is it? It is the obstruction now. Obstruction of these two glands, meibomian gland and Z's glands, they get obstructed. Rule of thumb, whenever you have a tube obstruction, you're going to get inflammation behind that. So that inflammation is known as chalazion here, which is a granulomatous inflammation. Okay. Then the last here is called xanthelisma. Easy. It's a yellow patch on the medial eyelids. So this is the eyelid. Here's the medial part. You get the xanthelisma there. Maybe associated with genetic and lifestyle factors, example, high cholesterol. So could be genetic or high cholesterol. You got to check the cholesterol levels, right? And that is going to be all for eyelid disorders and for this section.